Before the previous panel, we're discussing about multifocals in patients operated on myopia, hyperopia, and in combination with astigmatism, and that is present and the future that we will have, and the present that's already here. And those of us in the clinic, and we do refractive every single day, we see that laser surgery has been done for many years, 20 years. These patients age, and yes, you can do some retouch, you can do retreatments with laser to improve their presbyopia, but the evolution of the lens, of course, inextricably worsens. And a friend of mine used to say, he said, actually he's here, he says, your lens is your friend until it's no longer your friend. So the lens that worsens, well, worsens our presbyopia, and if you were operated on because of your myopia or hyperopia, you still want to correct your vision, and these patients come consult much earlier than other patients that were never operated on because they want to continue having a good vision. And why can we offer this to these patients? Well, we know this, and of course we are not going to teach you about multifocals now. It was a revolution in the field of surgery, because then these lenses would allow the patients that they had their cataracts and then they didn't need their glasses for far vision and near vision. And now patients with myopia, hyperopia previously operated on, they want to still see well, continue having a clear, neat vision, and also work well with their near side. And we have experience, because sometimes they come with refractive problems with the near vision, but the problem has worsened because now they have hyperopia or now they have myopia. So refractive changes affecting distance vision most of the time. So what is it we look for? As we've been mentioning all day long, quality and quantity of vision, because they come from a surgery, these patients, that worked relatively well most of the time, most of the patients, so they want to enjoy their vision. They see well, distance, now they want to have a good near vision. And their daily life, sports, the phone, the computer, working out, they want to do everything without having to wear glasses. They don't want to depend on spectacles, as we just said. And then we need to bear in mind that these patients, again, had been previously operated on, so they will have aberrations, different optical zones, astigmatism, multifocal. So not easy, but it's a choice so that these patients can not wear glasses. With multifocal IOLs, once they're implanted and with the right candidate, the patient will have a better vision, near vision acceptable. They can enjoy the fact of not having to wear glasses. And then the patient will recommend that surgery to friends of them that had been operated on in the past, myopia, presbyopia. What are the advantages of these lenses? I usually use diffractive, trifocal, multifocal IOLs, and neat vision, different distances, they don't need to wear glasses, better adjustment to their lifestyle, better patient satisfaction, and reduced visual fatigue, because no glass, no progressives, no changes, now the screen, now I don't need it. In order to select the right patient, you need to clearly identify the right candidate, because of course what we want is the surgery to be done well, to be recommended. We don't want any issues in the OR. We want to rest assured, because we are the surgeons and we are going to be prescribing the surgery. If the experience is good, we will prescribe more surgeries and better. We then assess the clinical history of the patient. We reassess the eye health. Of course, important. We heard it before. Topography, the eye, the retina. Then we can choose between a trifocal or a bifocal. There are not that very many. They're no longer being produced, but for high myopia patients, they want to correct their defect. Well, it's useful, and for their near side, if the refractive surgery had lasted long enough, it's good. Expectations of the patient, we need to talk to the patient, especially in these patients, because sometimes for these patients we require hypercorrections with a multifocal lens to then later on be able to correct aberrations. The previous panel, they were saying you can correct with laser aberrations first and then place a multifocal. Given the percentage of patients that we will have to retreat with laser, with multifocals, patients operated on myopia and hyperopia, at least that's what we do. We first implant the multifocal lens. When in doubt, we hyper-correct the patient, the opposite side, to then reduce this negative aberration, because the multifocals, IOLs in general, actually increase the negative SA. So depending on whether there's myopia or hyperopia, then we will do one thing or another. Oblate, prolate cornea. I'm not an expert, so I'm not going to teach you about cornea. These are treated cornea. You see here people with myopia, people with hyperopia. Remember that astigmatism, against the rule, as the more we age, they increase the general population until the age of 20, 30. We can find 10-20% of astigmatism against the rule. As we age, because of the changes in the cornea, that figure can be up to 30%, and there are patients that are hyperopic, and with time they, present with these corneas, with this astigmatism against the rules. It's very invalidating for a progressive or for night vision. Previously operated astigmatism with laser. So what are the results to be expected once we decide that we will go with a multifocal IOL? They all will improve, because if we operate their cataracts, they will improve. 6 months later, they improve their visual acuity by 20%. If they have presbyopia, we start off with very high vision, so the demand is higher, and our demand is, of course, even more rigid. So depending on the degree of the cataract, the initial loss of sight that they have, any change with the light entering. After removing a cataract, multifocal IOLs, the center of the lens lets the light in, so they will see just like they did when they were young. So more and better. These, speaking of cataract patients, 1 year later, 90% of the patients report that they are satisfied. They're feeling better, they don't use glasses, and in general, they're happy with the surgery. That's the result. Here, an outcome, some tables based on what we have been doing with some patients. We do some follow-ups on some patients in the past. 350 eyes operated on, not patients, 350 eyes. You see myopia, average myopia, you see to the left, vis-a-vis the type of lens that we've implanted. But I want you to really pay attention to the final part. Degree of satisfaction, degree of the patient, so, S for satisfied, MC for very happy. That's subjective, yes, but that's what they report. So we encourage patients with refractive problems that had been operated on in the past. We can use this, and we feel reassured, and we are, confident. Hyperopia, here we've used some eye hands at times, you see that, but with multifocals, fine visual. FT is fine vision with astigmatism. A4 for myopic patients with some retinal disorder. I usually go, the retinas that have macular tilting over 20-30 degrees. Bifocals is my choice. They feel more comfortable, and of course I tell them that they will probably need +1, +1.5 for the computer screen. And you see the satisfaction degree here is higher for hyperopics. And we've assessed the percentage of touch-ups or retreatments or bioptics with laser. You see 10% all in all, 10.1 actually of the eyes treated, 80% were myopic patients. Why? Maybe the compensation of aberrations, no, the increase of the aberrations because of the negative aberration of the lens with the positive aberration of the myopia. Maybe it doesn't work well with them, and then we need to improve it. Hyperopics, 20%. Out of all of the hyperopics operated on, 6.7%, we have had to do some retreatment to improve their vision because they were not happy, or there was residual stigmatism. And for myopics, operated on 11.5%. That's the figure. That's what we would like to hear from all the patients, right? After the surgery, I am now fully independent. I can enjoy my free time with no concerns. That is a transformative experience. Well, wonderful, but it's not as easy as it sounds. So, conclusions. Multifocal IOLs offer to these patients a good solution so that they can dispose of their glasses, reading glasses. So our lens we will customize for every patient. So, as we heard before, then we can have some personal nomogram that will help us be more or less successful in the surgery. And then these patients are patients that will enjoy the fact that they don't have to wear glasses and they don't have to use monofocal glasses, because then, of course, they don't feel as independent as they wish. Thank you.